Welcome to Advances in Radioiodine-Refractory Differentiated Thyroid Cancer. This program is provided by the Endocrine Society and supported by an educational grant from Bayer Healthcare Pharmaceuticals. My name is Maria Cabanillas. I'm an associate professor at the University of Texas MD Anderson Cancer Center in Houston. You can see here the disclosures for the faculty as well as the non-faculty contributors on this slide. Our aim is to ensure that the program is an engaging and meaningful learning experience for you. The educational objectives for this program are as follows. Personalized treatment selections for patients with radioiodine-refractory differentiated thyroid cancer based on available data and approved agents. Implement strategies to mitigate toxicities associated with radioiodine-refractory differentiated thyroid cancer therapies, and evaluate data from late-stage clinical trials of emerging therapies for radioiodine-refractory differentiated thyroid cancer. The standard therapy for differentiated thyroid cancer includes surgery to remove the thyroid and all of the involved lymph nodes, followed by radioactive iodine and TSH suppression. TSH is a growth factor for differentiated thyroid cancer, and therefore we like to keep the TSH low. This is taking us back to the 1940s and 50s when radioiodine was discovered to be helpful for patients with thyroid cancer. You can see here this gentleman in the Life magazine who was very thin, he was cachectic. He probably had a functional thyroid cancer producing thyroid hormone, and he was given 4 doses of radioiodine and was then cured of his disease. You can see here that radioiodine works beautifully for patients, and in this scan you can see a post-treatment therapy with radioiodine that's localizing to the lungs and possibly a little bit in the neck there. Radioiodine uptake can be heterogeneous, and so this photograph of a biopsy taken of a patient who had received radioiodine, you can see that the tumor here in the second picture takes up radioiodine at the very top of the tumor, but the bottom of the tumor has spotty iodine uptake, and so this can be problematic in our patients. Radioiodine also doesn't always work, and you can see in this publication from the 1950s that the authors state that the results of therapy of thyroid cancer with radioiodine have been disappointing due to the spotty nature of iodine concentration. This is a known problem with our patients, that some of them may take up some radioiodine, but not in all lesions, and some may not take up at all. Therefore, we do need to think about the indications for systemic therapy. The first indication are patients who have a symptomatic disease burden who do not take up radioiodine and cannot be managed with localized therapies. A second indication would be patients with clinically significant disease burden, and this is defined as target lesions measuring at least 1.5 centimeters in diameter and likely to cause symptomatic disease if left untreated. These patients should be radioiodine refractory, and we like to see that the patients have progressed within 6 months, although we can, on a case-by-case basis, consider patients who have progression within 12 months. And a third indication would be disease threatening an organ or limb function that cannot be managed with localized therapy, and I'll talk about localized therapy later on in this talk. We have studied many different drugs for radioiodine refractory differentiated thyroid cancer. You can see the list here. It is a long list, but of these drugs, the only ones that are approved for differentiated thyroid cancer are lenvatinib and sorafenib.